So hi everyone, thanks again for joining us today. It's a very exciting day, very amazing, really amazing keynote so far. So I'm Benjamin Haibe-Kains, I'm the Scientific Director of the Cancer Digital Intelligence Program. And we've heard of Alejandro Berlin, is the Clinical Director, so he's doing the smart, spicy questions and I'm doing the bad jokes. So we're a very complementary team. So today I'll be chairing the Remote Care Advancements in Oncology session. And I will introduce each speaker. After the talk, the speaker will go back to the audience, and the next speaker is going to be introduced. And we'll keep the questions at the end. Like this morning, we'll have a bit more of a panel discussion with your questions from Slido. So again, thanks again for posting those questions on Slido. They make it very entertaining. So it's my great pleasure to introduce Dr. Roxana Dronca. She earned her MD degree in Romania and did her residency in internal medicine in Michigan. She then completed a hematology and oncology fellowship at the Mayo Clinic School of Graduate Medical Education and continued her training as a Mayo Clinic scholar. So Roxana is now a consultant in the Division of Hematology Oncology in the Department of Internal Medicine at Mayo Clinic in Florida, and she serves as the director of Mayo Clinic Comprehensive Cancer Center and Florida Cancer Programs. And she's also a professor of oncology of the Mayo Clinic College of Medicine and Science. So Dr. Dronca has become involved with the Mayo Clinic in Florida and Mayo Clinic Comprehensive Cancer Center's effort to envision and set up the Mayo Clinic Cancer Care Beyond Walls program. We strive to create a new model of cancer care that integrates telehealth and digital technologies, so the topic of today, with traditional models of cancer therapies. And the goal is to provide high-quality cancer care that is responsive to the diversity of our community and patient mix. Again, some of those topics that have been discussed this morning. So really bring inclusivity in cancer care. So with that, Dr. Dronca, the floor is yours.
Thank you very much, and thank you for having me here today. It is really tough to follow the keynote lecture, but I am going to do my best to share with you the Mayo Clinic Cancer Care Beyond Walls program. Many reasons have already been discussed as to why we need a different model of cancer care delivery. Why do we need to disrupt cancer care? Well, the landscape, I think, oncological landscape is already or was already shifting even before the pandemic, moving lots of chemotherapy and treatments from the hospital to the clinic, to the outpatient clinics, during the pandemic to virtual care. And I think the next logical transition is to moving it outside of our walls, whether it's in the communities where patients live or in the patients' homes. Patient expectations, I think, have also shifted and changed during the pandemic. People realize that you can do things differently, and healthcare kind of lags behind, other domains, and I think we're trying to catch up. But I think most importantly, beyond patient convenience and building a patient-centric model, we also need, as healthcare institutions, to look at our ability to treat patients in the future. In the next couple of decades, the number of new cancer diagnoses will increase by about 50%, and we're going to have also even more cancer survivors because people now live longer, fortunately, due to our treatments. Close to half of them live beyond 10 years from diagnosis, many times undergoing successive lines of treatment. So we very soon will be outpaced in our ability to provide oncological services, and we need to think outside the box. So Cancer Care Beyond Walls was born out of these necessities and definitely out of an identified patient need. And it is in a hybrid model. It is not all in the home, it is not all in the clinic, but it is a smooth patient transition between home, virtual care, and hospital care. What do patients have? They have around-the-clock access to a Mayo Clinic care team through a command center that I will discuss more about. They have remote patient monitoring when needed. They have the ability to receive and to have blood work, laboratory testing in the home, as well as administration of cancer-directed therapies, whether it is intravenous, subcutaneous, intramuscular treatment in the home, as well as supportive care. At the core of the program is really the command center. The command center is staffed by chemotherapy-trained nurses, APPs, advanced practice providers, and they have oncology, medical oncologist oversight. At the other end is the patient in the home with the ability to have remote monitoring, not continuous monitoring, but on-demand and as-needed monitoring. The patients have a tablet that is very user-friendly. It has a big button, and I'll show you the tablet in the next slide as well, that it says, "Talk to my team." When the patients push that button, it rings into our command center, and one of our nurses answer. They have a technology pack, we call it, which is Bluetooth-enabled blood pressure cuff, pulse oximeter, scale, as well as thermometer, where patients can check their own vital signs at home, and the vitals are imported directly into the medical record, or the nurse in the home can check the vital signs if needed. We do have the ability to provide redundant internet access through a cradle point, but we also can do that for patients who don't have Wi-Fi in the home. This whole system is linked together by a software platform that links Epic with the system of outside vendors that provide the care in the home, and also the support of a community paramedic network for immediate patient needs. The command center, as I mentioned, is the heart of the program and really is responsible for doing many different patient tasks, from scheduling the treatment in the home, the laboratory work, the order of who's going to come to the home and when, from converting the chemotherapy plans. As we all know, that's very difficult and tedious to do, because you have to convert, for us, we're on Epic, outside Epic, into the system that now communicates with the home. In the future, we want to build a software that will integrate that very seamlessly, and the Mayo Clinic platform is already working on that. The nurses in the command center are also responsible for taking the patient's calls in between treatments. So if somebody escalates with a new symptom, the nurses have decision trees and algorithms from what to say to the patient to when do they need to escalate to an APP or to an oncologist. And as I mentioned, they also coordinate the transition between on-campus as well as home visits. This is the technology package that the patients have in the home. This is the tablet that they receive. Again, it also, beyond having the ability to connect with a care team, it also lays out the schedule for the patient, so they know exactly when the nurse was going to be in the home. They are not sitting around the whole morning to see when the person who brings the supplies is coming or when the nurse is coming. The remote monitoring, we are not doing continuous monitoring, one, because we don't need, and two, because with that would come a whole system on how you analyze and respond to continuous data. And these are outpatients. This is not hospital in the home. These are outpatients that otherwise would not be monitored continuously. So we have chosen to do, again, on-demand monitoring and symptom assessment. This is what happens to the patient. So once they start the treatment in the home, a couple days before or the day before the person who's doing the technology installation in the home comes, they also have education. They also get education from our chemotherapy nurses in the command center in terms of what will happen in the home. The day before treatment or the day of treatment, patients will have labs, just like it happens in our infusion units. And then when the lab is resulted, they have a virtual visit with one of our APPs. If the treatment is safe to proceed, then the chemotherapy orders are placed, and our pharmacy, which now has a home health license, will compound the drugs, and then the drugs will be transported to the patient home, where a home health nurse will meet the patient and administer the treatment. During the treatment administration, our command center nurses are online with the home health nurse at all times to do the dual person verification, to do any troubleshooting that is needed for the nurse in the home, hazardous medication disposal, any questions, any infusion reaction if one arises. There is an anaphylaxis kit that is actually provided to the patient home at the time of the technology pack that has the ability to treat an infusion reaction just as in the chemotherapy unit. The home health nurses are not chemotherapy certified, but the Mayo Clinic program has developed a training for these nurses that happens at least twice a year, and provides provides also hands-on training. Once the treatment is complete, the nurse leaves the home and the patients resume their life as usual. What does this also add, in addition to just the treatments in the home, is the ability to be proactive in terms of management of complications of the treatment and or the cancer. In between treatment cycles, if the patients have new symptoms or questions, they can reach the command center, and again, our nurses can advise what to do. We're already seeing that this proactive management of symptoms is decreasing the number of patients that come with grade 3 colitis, or grade 3 side effects, to addressing symptoms and treating symptoms sooner. For certain regimens, we're also building an algorithm where our nurses will proactively ping the patients with questions. You don't want to overwhelm the patient with too many things coming online for them to complete, but you want to choose the treatment regimens where you want to assess every few days or once a week how the patient is doing. For treatment regimens that have multiple weeks, for instance, day 1, 8, and 15, you don't need to have an APP before each treatment, but we have one of our chemotherapy nurses meet the patient, for instance, before day 8, once labs are done, to go over labs, see how they are doing, so reproducing the workflow that we have in the clinic. This is what I was talking about in terms of being proactive in symptom management. If the patient calls the command center with a particular symptom, mouth sores, nausea, vomiting, diarrhea, our command center APPs have the ability to dispatch supportive care in the home, IV fluids, IV antiemetics, etc. So far, anecdotal numbers, because we are analyzing data now, more than 85% of this clinical scenarios, we were able to de-escalate them and keep them in the home. And as you will see in our clinical trials, the ER visits and healthcare utilization through acute care visit, ER visit, or hospitalization is one of the key points, and indeed we think that this will help decrease those. So initially, when we pitched the idea, this is exactly how it was described before. A small number of us went and pitched the idea to Mayo Clinic leadership, and we said, we think that this, could be something that cancer patients could benefit from. We did have the hospital at home program during the pandemic at Mayo, which became hugely successful, and we said we have a little bit of a blueprint. We can partner with them. We have the know-how in oncology. Let's see if we can make this work. And initially we were, given the nod, okay, go ahead. We were given the team, the SWAT team that we were talking about, to see if we can implement this. And we chose 10 patients. We did a proof of concept clinical pilot. Chose 10 patients. It happened that 9 were colon cancer patient, 1 was a breast cancer patient, and we said, we'll do 2 cycles in the clinic, or if the treatment is ongoing, we'll do 1 more to make sure that the treatment is tolerated, no infusion reactions, and then we'll do 6 months in the home, and then you'll come back and you'll resume your care in the clinic. We did close to 200 or 120 infusions through this pilot, and the patient feedback was tremendous. 1, we had absolutely no infusion reactions and no side effects, and the feedback from patients was extremely positive. Actually, 0 out of the 10 patients wanted to come back to clinic at the end of the 6 months, and we had to extend the pilot beyond 6 months at patient request. So no one wanted to resume the care as before. An important aspect that I should mention is that patients are not, it's not out of sight is out of mind. Patients are not managed now by the command center. The command center works with the patient's oncologist who makes all the decision and their care team. So if a patient is GI, the command center works with the GI team to make sure that the continuity of care is there, and the patients come for the scan visits on site and comes to meet with their care team as they need to. As the program grows, we're actually now putting the care back into the care teams, and a lot of our APPs who are in those care teams will actually going to be doing now the virtual clearance, so it's even more cohesive in terms of patient care. So once that pilot was completed, we opened 2 clinical trials with 2 more to open that I will mention. The key is having the data. If we say, oh, this is great and patients really like it, can you give us reimbursement for this? No, CMS won't do that, and no one will do that. Everybody's asking for objective data. Give me the patient's outcomes and give me objective data. So we opened the first clinical trial, randomized clinical trial, where we give patients care in the clinic and in the home. You see here both arms have care in the home. It's just staggered as to when they begin this. Our statisticians work with us to make sure that we can analyze the outcomes and compare between arms and also each patient to themselves. We wanted to do in the home only and in the clinic only on the randomized arms, and actually patients did not want that. Doing a focus group and looking at our hospital at home clinical trial, all the patients in the hospital at home who are assigned to the care in the clinic were dropping off the trial. So we wanted to make sure that we have patient participation, equal participation in both arms. You see here the patient outcomes. The main outcome is patient preference, patient's voice, patient preference with the site of care, and patient experience with the care in the home and in the clinic. We have an extensive CAP survey that will capture all of this. Secondary outcomes are safety, the percentage of grade 3 and higher adverse events related to treatment administration in the home. We're not studying a new drug, we are studying a location of treatment. So the intervention is the administration of the treatment in the home versus administration in the clinic. And then we have quality of life for patients, we have clinical outcomes and healthcare utilization, and then we have an exploratory endpoint for analysis of cost of care. These are some of the inclusion and exclusion criteria. Basically, we have I will show you the drugs that we are administering, an approved treatment plan, making sure that the patients will complete the months in the home, so the treatment plan is long enough. It doesn't stop after 4 cycles, etc. And at the time, living in the service area of the vendor network, which was initially 30 miles, we're pushing now to 75 miles, 100 miles very soon, and we want to expand all the way to the Florida Panhandle very soon. And for those of you who know the Florida Panhandle, there is almost no oncology care there, and that is actually the main goal of this program, to reach patients that we cannot reach today or they cannot reach us today. These are all the drugs that we are giving in that randomized clinical trial, and you see here it's a hodgepodge. This is not a specific cancer-directed treatment, but it's the drug that is chosen. Drugs that are stable, 24 hours or more to be transported, have a low reaction percentage, and we chose this as well based on cost. Initially, this trial is supported by Mayo Clinic Comprehensive Cancer Center, so we don't want to break the bank with the $30,000, $50,000 drugs. But these drugs can definitely be expanded to more. This trial is a second trial that we opened in April of last year. This trial is fully funded by BMS, and it studies the administration of subcutaneous nivolumab in the home. This was started before the approval of subcutaneous nivolumab. I think it's even easier now once it was approved. Again, similar concept. Patients get 2 cycles. Patients for any FDA-approved indication of IV nivolumab, patients are given the choice to switch to sub-Q nivolumab and then to receive a portion of their treatment in the home. After 2 cycles in the clinic, well tolerated, they receive 4 cycles in the home, and then they resume care in the clinic. The third project that we have going on is funded by the Department of Defense, and this is part of the funded Eye Care Consortium, Inclusive Cancer Care and Research Equity for Black Men. This is funded by the Heroica grant mechanism, which some of you may be familiar with. It's a partnership between 4 institutions. It is led by Mayo Clinic. Dr. Falakio Dedina is the leader of the consortium, and I have the project 2 of this grant. This consortium is funded in 2 phases. The first phase funds pilot projects, and then if successful, then a larger funding is being given for clinical trials. So my initial pilot was to really, again, listen to the voice of the patient. Is this something that patients would want? What is the impact, acceptability of a model like this for Black men with prostate cancer specifically for this project? For this, we are doing we're doing a set of questionnaires for patients that is really looking at the pros and cons in patients' eyes of having treatment in the home versus in the clinic. Is it more important that you don't have to park, you don't need a caregiver to take you, every time, that you can receive treatment in your familiar environment, you're more comfortable there? Or is it more important to you that you are in clinic where you know it's the same nurse that is giving you that, you're under, the doctor's eye? So we really wanted to see what are patients valuing more. The trial, or the second part of the consortium was successfully funded a couple months ago, and we are opening now the clinical trial where we are offering patients with advanced or metastatic prostate cancer hormonal treatment or chemotherapy or immunotherapy treatment in the home. So we think that this is more than practice changing. I think it's paradigm shifting and shifting our thinking, not only to develop a patient-centric model, but to develop the framework by which we are giving also decentralized clinical trials. You have to learn how to administer standard of care medications in the home before you go to a phase 1 trial in the home, but the road is not that long, actually. Now that we're comfortable with this, we're actually thinking to give a cancer vaccine that's in a phase 1 trial, potentially in the home. We are opening a clinical trial with an intravesical in the bladder, treatment in the home. So I think the steps now are a lot faster than the initial steps. So I'm going to show you a video. I think I'm over time, but I would love for you to see this video.
Put me in this program that you can do this at home, would that be your choice? And I jumped on it and said, let me be the first to do it. I couldn't be any happier. My quality of life is up here. I'm able to be with my sister. It's just such a convenience that I could go walk, check my time. Okay, my nurse is going to be here at 9. Pop in, get my chemo, my infusion, and then I go back out and continue my walk. It's been a convenience, is what it is.
This program of getting your chemotherapy at home has changed my life. As a PE teacher, I don't have to miss school days anymore. With this program, I can teach without worry. I feel so great. My quality of life has changed significantly to a point where I never thought I'd be.
Being on this path that we're on right now, where being stable and being able to be right here at home and being able to do all the things that we've been talking about doing and actually going to do them, being able to look forward to things after going through the times where we didn't think he was going to make it, to going to plan vacations and futures, and it's just exciting and wonderful, and it's awesome.
Thank you very much for your attention.
Thank you very much, Dr. Dronca. So it's my pleasure to introduce Dr. Stéphanie Lheureux. So Dr. Lheureux is a medical oncologist, clinician investigator, side lead of the Gynecology, Oncology, and co-director of the Beyond Chemotherapy program at Princess Margaret. She holds the Westerway Chair in Ovarian Cancer Research and is an associate professor of the Faculty of Medicine at the University of Toronto. So our clinical and academic interests are focused on gynecology, cancer, and early drug development with an emphasis on translational research. So she's leading a lot of clinical trials here at Princess Margaret. With that, she has many, many accolades from all over the world, and I would love to give you the floor. Thank you.
Thank you so much for the introduction. It's a real pleasure to be here today. It was very mind-opening, and Here we will talk a little bit about our pilot, because I'm a clinician, so I'm good at doing pilot. Then I definitely understood that I need to transform, but I need a team to support this. So here's a story about what we have done in our gynecological group. And to give you a little bit of background, it initially came with a problem. And in clinic, we have a lot of problem with our patient with gynecological cancer, because gynecological cancer, when it's progressing, it progresses a lot in the abdomen and compressing the bowel. So these patients actually have a lot of symptoms when the cancer is progressing. They have vomiting, nausea, they feel full, they can't eat, they're constipated, they have edema, they have pain. And because of that complication, these patients often go to the hospital, go several times in the emergency, they are admitted for a long time, and then concerned about 50% of a patient with ovarian cancer. And as you heard, right now, the quality of life of this patient is a major component. And with malignant bowel obstruction, you definitely don't have a quality of life. And that leads to a poor outcome. And unfortunately, bowel obstruction, I do a lot of clinical trial. There's no trial with malignant bowel obstruction. No clinical trial allow malignant bowel obstruction because it's a significant complication and impact how the patient feels. So because of this problem, we say we need to help this woman. These women were admitted for a long time. And what is also important is that most of the women were not aware that can happen because they have ovarian cancer or endometrial cancer. What is about the bowel? Why have a bowel problem? So we actually have a champion in our team, which is Nazlin, the nurse, and actually we try to say, okay, how can we have a new model of care for the patient with malignant bowel obstruction? So we have actually identified 5 big components to try to help them. And that's really a proactive interdisciplinary approach to try to see how we can manage this patient outside of the hospital, to do outpatient management. So first of all, we need to be proactive and identify the risk to develop malignant bowel obstruction before it happens. So we have identified some clinical criteria for malignant bowel obstruction. And with the discussion yesterday, I was thinking maybe we need to go beyond the clinical and maybe have other new tool and maybe AI tool to identify that proactively as well. Another important criteria is we need to triage the patient. So which the patient are at risk, who the patient who have early diagnosis of malignant bowel obstruction. So with the help of our nurse, we actually developed this specific risk triage system to be very practical in clinic. So we have a color system which is red, which is patient with diagnosis of malignant bowel obstruction, we need to be admitted. Orange is that patient have a malignant bowel obstruction, but we think we can manage that outside of the hospital. Then you have yellow, who is a patient at risk. Green, they have no malignant bowel obstruction, and blue is unfortunately patients that need to be in the palliative care setting. So then after we actually have standardized all our process, because when you treat patients with malignant bowel obstruction, because it's seen as a poor condition, unfortunately there's no guidelines. So the patient was treated very differently between even in our own institution. So we actually, thanks to Nazlin, developed a very standardized process to assess this patient with a specific nursing documentation as well. Another component that is important as well is, as I say, like most of the patients with gynecological cancer didn't think about the bowel because it seems to be different. But actually, there's a lot of impact on the bowel, so it's very important to have an appropriate diet. And sometimes when patients have a risk of malignant bowel obstruction, they are constipated, so they think they need to eat a lot of fiber because it helps with the constipation. And it's absolutely the contrary. So we have done a lot of education about what patients can eat, what they can't eat, and how we can help them. And actually, we're trying as well now to work with a chef to actually have specific recipe for them as well, and try to help them with all the medication about stool softener that can be sometimes confusing. So we have worked a lot about the education for patients and also the nursing. So then after we try to see, okay, can we use this framework to actually improve the outcome for our patient? So actually we have this specific system when we triage our patient, and the nursing was calling the patient, following the patient outside the home. So it was mainly based on a nursing triage and a nursing follow-up. And we did this retrospective review to see if we can improve our outcome. So we definitely improve our quantitative outcome. With this specific malignant bowel obstruction program, where we follow the patient prospectively, we actually decrease the length of admission and the visit to the emergency department. So definitely show that this pilot program can improve the outpatient management. And we also improve the patient outcome, because actually the patient were living longer than the standard of care when we didn't triage patient for malignant bowel obstruction. So definitely a quantitative outcome positive. We also did a qualitative improvement assessment, and actually from the team perspective, the team were feeling much more comfortable to care for this patient because everything was very standardized. We have guidelines, we have documentation to support the care for this patient. And from a patient perspective, we actually even publish as well this work because definitely the patient feel much more supported to have the knowledge to actually how to manage the bowel, what to do, what to expect, really improve how they felt, and they feel less isolated and really know how to manage themselves as well. So then after this pilot MBO program was successful, we tried to implement that in practice. Try to go to this transformation level, and definitely I can tell you it's definitely not easy. And we try to have this standardized medical management outside of Princess Margaret, so we publish all these guidelines in a specific paper, and it's really a well-rated paper, and we have a lot of coverage from outside, but you realize that every hospital have a different way of managing these patients, so how we can standardize that outside of Princess Margaret. And one of the challenges that we saw is actually the resources, because as I say, this system was based on the nurse calling, the nurse organizing the IV hydration at home, the nurse following regularly by phone. And as we heard this morning, if you increase the workload, it's actually difficult to implement largely at scale. So that was one of the barriers that we have seen, and it's a time consuming because it was in addition to the usual work that the nurse has to do in clinic. So we try actually to see, okay, we have another problem of implementation. How can we move this forward? So we say we need to use our new AI tool and maybe have innovative solution. So we try to say, can we actually have a mobile health application that we can use? Instead of having the nurse calling them, following them, can we develop an app to actually follow all these patients outside? And instead of the patient waiting the nurse to call, they can actually fill on the app all their symptoms, and the nurse will follow up with a specific triage system. So thanks to this brilliant team, actually, we conducted another pilot of assessing a new app for malignant bowel obstruction. This actually was also published in the Gynecological Cancer Journal, really showing the feasibility of an app for patients with malignant bowel obstruction. So really the goal was actually to try to decrease the nurse load and to have the app taking care of all the triage system and not having the nurse doing that prospectively, and try also to have all the documentation for patient and nursing in one place. So here is the algorithm that in clinic we used. So that was also one of the challenges because it's complex. It seems very complex, but actually when you go step by step, it was easy to follow in clinic. But how this algorithm that we use in clinic can be translated in the app. That means that actually each questionnaire that the patient receives needs to be customized. So that was a lot of work actually to ensure that each patient, depending on the risk of malignant bowel obstruction, depending on the status of the bowel function at that time, have a specific questionnaire adapted to them, because we don't want them to have a questionnaire if they have malignant bowel obstruction or if they don't have. So it was a lot of work actually to try to translate this algorithm in this specific app. So here's a kind of a snapshot of what the patient received. So we developed this app, so they can have this app on their phone or tablet or computer. So it's how it looked like. So it was really customized to each patient. And here, this kind of question that the patient received, they can complete this at the time they want. And here's some of the questions that they received. And then depending on the answer, then the nurse, and again, we can call about the command center, but here was a nurse that was in charge of the MBO program that receives this alert. So depending on the question and the answer from the patient, there was some specific alert. So if actually the patient were answering they were feeling well, then there was no alert, it was green. So green, the nurse actually didn't have to call them, didn't have to do anything. The patient actually received some notification on the app saying all is good, continue. If the answer was actually concerning, then it was sending a red alert to the nurse. And then that actually lead to specific action from the nurse to follow. So it was a kind of a triage system as well for the nurse to act early on for the patient who have a red alert compared to the one that don't need any specific intervention. So here is how the nursing dashboard looked like. So this was a specific application that the nurse have on their computer, so they had to log in. And then here's an example of, for example, here you can see that one have a red alert, one have a yellow alert, so it helped to triage the patient. And here as well, because documentation in the healthcare system is very important, it's important to actually have the nursing documenting as well. So for every patient where there's a red alert, actually you can see here that the nurse has, and it was really synoptic to actually what the action the nurse took for this specific patient. So everything was really well documented as well. So in addition to this app, what was also very interesting for the patient is that they can call and request a phone call. So even if there was something else going on that was not answered by the specific question, they have the possibility to request a call, and they also have the possibility to send specific message. So instead of waiting for the nurse to call, they can also write a specific message on this specific app. And as you can see here as well, the app also have all the resources that we have developed for the patient education. So everything was available for the patient to actually have access. We even developed some specific video about malignant bowel obstruction, and we have a lot of views actually now on YouTube. So it's actually exploding the views. So really showing that there was a need for the patient. So what did we learn from this pilot app application? So actually the first question was, do we have a good adherence to this program? Do the patient actually do it? Because when you need to imagine this patient with malignant bowel obstruction can be very symptomatic. They have a lot of symptoms, they're at home. But actually, the 2-month symptom question adherence was good, was at 65%. We definitely need to improve because as a physician, we don't like the click. The patient may not like the click either. So we definitely need to do some customize of improving this kind of function. But for this specific population, 65% was thought to be a good adherence. And then the patient with symptoms can continue this program for as long as the benefit, so beyond the 2 months. And you can see here that the adherence was 60%, so still a very high adherence with time. So in terms of the alerts, so were you good at actually selecting the patient? Did the algorithm was matching well with the app? And yes, actually the sensitivity of the alert to prompt recommendation was good at 72%. And actually we can see that in this pilot study, we have 65 symptom-related alert in 60% of the patients. So when you look at it in this pilot study, 40 patients didn't require action. So actually we gained time because we didn't have to call them, their need was answered. And then in 60% of the time, we were able to classify and stratify this patient and call the urgent one first because they were red and then yellow, and actually prompt some specific recommendation. And what was also interesting from the app, what we learned is actually 97% of the patients actually use this function. So they actually really like to still keep connection with our team by specific messaging, and the answer was during the day, so there was no specific wait time for the patient either. And then after the patient stopped the app for different reasons, because the program was completed, and actually you see that the patient withdrawal was only 10%. So really, I think that was actually a very interesting program for our patient. So what we do next now is to try to implement this system in Epic, because this app was actually outside of the Epic system, so it's another workload as well. So we try to see if we can integrate that in Epic for a more suitable workload for our system and our patient. So with that, I really want to thank our team and our patient that make this possible, and thank you for the meeting to have me today. Thank you.
Thank you, Stephanie. Talking about economical growth, I hope you collect the revenue from your YouTube views.
I think I need to go to the training session.
Okay, so YouTube as a new source of revenue for healthcare. So for my next talk, it's my pleasure to invite on the podium Dr. Christine Chen. So Dr. Chen is a clinical investigator with a focus on novel approaches, particularly driving implementation science, initiatives moving CAR T cells and other complex immunotherapies into the outpatient and community settings. So very important topics for today as well. She currently holds the UHN David and Molly Bloom Chair for Research in Multiple Myeloma, and she's an associate professor at the University of Toronto. And she's very importantly the medical director of the Clinical Immune Effector Cells IAC program at Princess Margaret. So, Dr. Chen, welcome.
Thanks very much. So today I'd like to talk about our cell therapy program. Cell therapies include stem cell transplant and more recently CAR T cell therapy. And these are therapies that are resource intensive and complex, typically are performed as inpatients and at large academic institutions like Princess Margaret. So we've initiated processes to try to shift this type of care into the outpatient and community centers. And I've been fretting since yesterday, realizing this is a digital symposium and that we're very low tech, but I'm hoping that this will initiate a lot of collaborations to help us incorporate digital technology. So these are my disclosures. Many of you know about stem cell transplants, which we've been performing for over 30 years, but CAR T-cell therapy is pretty new. This is a bit of a primer. So CAR T-cells originate from immunologic T-cells that we collect often from the patient, and then we genetically engineer them ex vivo into CAR T-cells that actually are able to recognize and target cancer cells, and then in the process of targeting will actually kill them. So with one single cell infusion, these cells are living drugs and they can remain in the system for weeks, months, even years, keeping cancer at bay. And in patients who are heavily pretreated and relapsed, so for instance, lymphomas, who normally have a median survival of 6 months or less, we can actually cure almost half of these patients. So truly revolutionary therapy that we want to bring to as many patients as possible where there's efficacy. Unfortunately, we're very hampered by the fact that these are very complex and expensive and resource-intensive treatments. This figure really just shows the many steps involved in just manufacturing the cells, where you collect T cells from patients via apheresis. You then ship them out of the country to a manufacturing facility where they are converted into CAR T cells through genetic engineering, and then they're shipped back frozen to where the patient is. And the patient then receives chemotherapy and the cell infusion, but there's a whole array of toxicities that can occur upon cell infusion. These cells activate and release cytokines that can cause fever, hypotension, and many other organ impairments. And patients stay in hospital at least 2 to 3 weeks, maybe often more, and a third of them may require ICU support. So you can imagine how bed shortages can increase wait times by even a small amount that really significantly increase mortality in this very needy population. So we are shifting the CAR T-cell therapy into the outpatient setting using a model that we've developed with our much more longstanding autologous transplant program. We opened our outpatient program for transplant 10 years ago, and we center it around our day hospital, which is shown here, where we have 6 chairs, and we're open 7 days a week. We perform over 150 transplants a year through this unit. And what happens is patients come here for their one-stop shopping. They come every day and are monitored through the acute period, but they get their chemotherapy, their stem cell infusion, blood work, transfusions, hydration, whatever is needed in this one unit, preventing patients from having to move around the whole hospital. And then if they are unwell and need to be admitted, then our admission unit is just adjacent to the day hospital, so there's a very seamless transitions of care. But no outpatient program would be successful unless you're very careful with your patient selection. So when we opened our outpatient transplant program 10 years ago, we reviewed our inpatient data and identified risk factors for complicated hospitalizations and sort of translated that into a really easy checklist that can be applied by our coordinators. So if patients do not have any of these high-risk features, then we think that they may be amenable to outpatient care. We're adapting this now for CAR T-cell therapy. But besides the medical indications, we also have a number of logistical criteria to make sure that patients can be managed safely in the outpatient setting. And one is that the patient must live or stay within a 45-minute drive of the hospital. They must have a 24-hour caregiver, and they must be able to have some kind of form of transportation that's not public transportation that can get them in urgently at night if needed for urgent issues. But we quickly recognized when we audited our data that up to 50% of our patients do not have a caregiver or live too far from the hospital to meet these logistical criteria. So we've been slowly hacking away at these barriers. A number of years ago, a condo company approached me and said that they had some empty space in their condos. We would like to use them for our patients. We quickly hooked them up with a business-minded husband of one of my patients, and they've formed a company where they use unused rental space in condos in the downtown core from multiple condo companies, and they match them to patients needing to relocate to our center for their cell therapy for a much discounted rate and sometimes even free of charge. We also have a very generous previous transplant patient who donated several parking spots for us so we can offset transportation costs. And we also are currently working on an initiative where a personal support worker can be a caregiver surrogate and be stationed in the Princess Margaret Lodge, which is where patients stay for short-term care. And when they need to come in for radiation or transplant, they can stay there, and it's not far away from the hospital. And that way, they can take care of 2 or 3 patients who don't have their own caregiver. And this is also a ripe opportunity for us to embed some smart home technology. But one of the biggest barriers for CAR T, at least, into shifting outpatient is the severe acute toxicities that can occur that are related, as I mentioned before, to cytokine-related release from the activating CAR T cells. And these toxicities are not only potentially very acute, they can occur as early as 1 hour after we infuse, but they're frequent, incidents up to 100% in with some CAR T constructs. They can be severe with 1/3 of patients needing ICU and very unpredictable. So there's a whole set of neurotoxicity issues that arise that range from just being unable to speak properly or losing their ability to handwrite to seizures and coma. So we mitigate this in hospital with a high nursing patient ratio, frequent vitals monitoring. We've got a special neurotoxicity screen. We have mandates for expeditious treatment with anti-cytokine therapy like tocilizumab. We keep the tocilizumab in a special cupboard close to the ward so that we can avoid having to go through pharmacy in times of need. And we mandate that it's a 1 hour time from ordering to the administration, and we audit that. And then we have a whole slew of after hours rapid escalation processes in case patients deteriorate. So you can imagine that this is challenging in hospital, let alone having to transfer these kinds of policies into the outpatient setting. And I simply show that this is our EPIC flow sheet for just part of the monitoring we do in hospital for the cytokine release syndrome that occurs with these patients. But this is, even though this is even onerous as an inpatient, I think it's challenging to implement in the outpatient setting, but there's great potential here to make use of wearable devices for continuous monitoring. As I mentioned, these patients also can get neurotoxicities, and we have our nurses apply at least 2 or 3 times a day a neurotoxicity screen, which is really a set of questions about orientation, and they also write out a sentence every few hours to see if dysgraphia occurs, which is like changes in handwriting, which is an early sign of deterioration of neurotoxicity. We're also looking at this tremor app, because tremor also is one of the earliest signs of neurotoxicity. So we put the phone on the back of the hand and just can check your amplitude and frequency of tremor and see if that may be an early detection device that we can implement in the outpatient setting. But currently what we're doing, as I mentioned before, is pretty low tech. We actually give patients who are destined for home monitoring a blood pressure cuff and oxygen saturation machine. They have a thermometer, and we train the patient and the caregiver to perform vitals multiple times a day. The caregiver also applies that neurotoxicity screen to the patient several times a day, and then they document it. And we, on the days that the patients are not actually seen in person, we call them from our day hospital and twice a day and make sure that they report the data to us. And so this is obviously ripe for a ripe population or setting for remote monitoring devices that can be linked directly to our EMR system. And so there are a whole bunch of other processes we put in place to operationalize outpatient care safely. So the same nurses who man our outpatient day hospital also are on the ward, so it's the same nurses who take phone calls 24 hours a day as well. So they're all well-trained in cell therapy and provides continuity for our in and out patients. We have a special alert card just for CAR T patients that takes them, has a phone number that's dedicated to just our service. And if patients are needing admission, then they bypass immersion. They are just directly admitted to our ward. And that allows us to keep expertise in-house and keep our timely administration of managed treatment. And we, as I mentioned before, we audit and enforce all of the metrics to keep timeliness in terms of management, because time is of the essence to prevent deterioration. Our inpatient unit is adjacent to the day hospital, so we use very similar inpatient level acute services for these patients. We have a special drug supply, as I said, for drugs like tocilizumab right there, so that we avoid having to wait for pharmacy. And then because we have a lot of inpatient overnight trainee staff who cover on call, we make sure we have a fulsome education and support system to make sure that they, if they have any issues at night, they have access to management guidelines. But not every patient, we know, can go into the outpatient setting, no matter how much we put in place for safety. So we have this other alternative, which is a shared care initiative. We call it Day One Transfers, that we initiated with our transplants, but we'll be looking at for CAR T as well. So this is just the timeline for a transplant where they get their high-dose chemo and then their stem cell infusion on day 0. And then there are a couple of days before they actually start to get cytopenic and run into problems. So in that time frame, which is like day 1, day 2, we will do all the work here at our hospital prior, and then on day 1, we actually transfer them in the ambulance to their local hospital where they do the rest of the recovery in-house there. And that allows the local team to take care. They are engaged. These patients know them. And we support them with regular MCC conference meetings to review all the patients. And of course, we're available at all times. We do training with these remote centers. We currently have 5 day 1 transfer centers that collaborate with us. And then just lastly, CAR T is not the only complex malignant heme therapy that's out there. These bispecific antibodies are quickly coming into standard care. These are drugs, they're not cells, but they're drugs that can induce the same kind of immune effect as CAR T cells, and can also lead to the same kinds of toxicities. And therefore, when we're just starting up these drugs, patients usually have to be admitted for close monitoring for anywhere from 7 to 10 days. So to avoid all that, we've been developing, we have a project where we're developing the step-up dosing policies as outpatients. We've developed and completed, actually, a user-friendly handbook, both electronically and in hard copy, and we're now rolling out to some of our Princess Margaret Cancer Care Network partner sites. And this is just an example of the table of contents. So again, ripe opportunity to enhance our collaborations with digital technology for better communication, education, and also for monitoring. So in summary, our complex cellular therapies, which are really difficult to even manage in-house, are slowly moving into the outpatient setting in the communities. It enables patients to stay in the comfort of their own home locally. It engages the community medical team and creates capacity for both us at academic centers and in the community. And as I hope I was able to show you, we have many potential opportunities to integrate remote monitoring technology, which I'm sure will enhance the safety and efficiency of our processes. So thanks very much.
I will invite the other 2 speakers to come on stage. So thank you for the questions from the audience. We have roughly 7 minutes, so we'll go quick. First, maybe a spicy question from Keith Stewart, and I'll actually extend it to all the panelists. So, is cancer beyond walls financially sustainable? It seems to be costing more expensive, to be more expensive. But I saw in your slide that you said it was less expensive. So, can you care about commenting and then maybe talking about the value of decreasing the cost?
Thank you, and I would expect nothing less but a spicy question from Dr. Stewart. Yes, actually there is data from European models that this is actually cost effective in single payer systems. So there is published data from France and England about cancer care in the home being less costly, and this was with low tech in the 90s and early 2000s. The cost of cancer care in US, definitely we can compare, right? It's apples and oranges, but the cost is not necessarily of the treatment that you provide, but you have to look at the cost of cancer care over periods of time, 3 or 6 months period of time. And we know how much it costs, for instance, is published data in US to take care of a colon cancer patient or a lung cancer patient over 6 months. One hospitalization or one ER visit is $15,000 to $20,000, which covers the cost of care in the home, for many months. So that is one aspect of the cost, and we're actually looking at this. A number of the drugs that we are given, that we are giving through Cancer Care Beyond Walls, we're looking at what patients are receiving those drugs in our practice today. And a number of those patients are very high utilizers of healthcare and of ER. For instance, we're giving cisplatin and etoposide in the home. You can imagine how, a patient with that type of medication, how many times they're actually seen for complications. So is looking at the total cost of cancer care, what can you de-escalate in terms of acute use of resources? And then there is the aspect of opportunity cost that is a little bit more difficult to quantify, but is there. If I don't see a patient that receives a 30-minute IV nivolumab in 1 hour chair time, how many patients can we see and what type of regimens can we give, in place of that patient? Or a Lupron injection. We've quantified, we have 186 hours of Lupron injection chair time a month that, you actually can treat much more complex patients, let alone that prostate cancer patient doesn't want to drive for a Lupron injection. So if you look at, everything together, I think it will end up as you scale the program.
And I think you bring an important point that it's a multifactorial equation. And when you look at the taxpayer, the patient, and the hospital, there is a lot of factors that may come into that equation. So I don't know if the other two speakers would care to comment about how they saw cost effectiveness or getting more expensive in their own program.
For our pilot program on the malignant bowel obstruction, we included a cost-effective assessment. And actually, this patient, in the past, these patients with malignant bowel obstruction were always admitted in the surgical bed. And you can imagine surgical beds are very precious because they need to go to the OR, so they were delaying potential surgery. So we actually completely transformed how this patient has been taken care of, and even thinking of having patients stable enough to be taken care of at home with a malignant bowel obstruction. So really decreasing the admission, the ER visits, so that actually is definitely costly. And what initially was time-consuming was when the nurse was calling all of them every time. And that's why we tried to develop this app to actually remove some nursing time to have the patient first answering this question and having this triage system alert to actually really call the patient that needed. So I think when we included in our health economic system actually was in benefit.
Thank you. And Dr. Chen, you're dealing with a very, very, very expensive treatment modality. So what have been your assessment?
Well, there's no question that moving care into the outpatient setting is going to be much cheaper than inpatient. Particularly when we looked at our transplant data, which is 10 years old now, we know that we have dropped the median duration of stay or usage of beds for these patients from a median of 14 down to like 2. So that alone, just counting the costs associated with beds makes this a very worthwhile endeavor. We haven't really looked at it officially for CAR-T. The CAR-Ts have a higher rate of readmission. We still use all the same other processes, inpatient versus outpatient. The same antibiotics are used whether they're in or out. We attach an AIP pump if they need antibiotics and don't try to change the processes much. And that allows us to do this seamless kind of transitioning back and forth. So there's no question, and this is shown over and over again in different settings, that outpatient care can be very cost effective.
Thank you very much. I'll end up with one question, pretty tricky as well, so be prepared. So going by ever-expanding healthcare need, we recognize virtual care is complementary in patient management, but this also requires both AI tools and human resources and time. When this volume reaches system tolerance, what next? How far can we expand these capabilities? So it's really about, I suppose, once you develop a system but you reach capacity, how do you go about your next step?
I can take a stab at this. I think it's important to remember that you don't have to do it alone. You have partners, right? So when as you scale up, what we've noticed is as we scale up, we have partners, right? We have the vendor network we're working with. We have our partner Medically Home. If we reach capacity with Medically Home, who can we work with? And actually, it's impressive how many different companies and/or systems, healthcare systems are out there that can contribute to parts of the program. So we do the same thing as we scale in patient care in the clinic, right? We have more patients, we have to adapt. And I think this is exactly the same with the system.
Thank you.
And I think it's what we were discussing a little bit this morning about the challenge of the implementation that need to be, it's a different skills that need to be think ahead of. So I think the pilot are very good, but then after the implementation and the scaling go as with the implementation and really try to have a broad scale for implementation and using, for example, the community center more than we currently do.
Yeah, and I'll just reiterate that because we've already hit a little bit of a max in terms of our 6-bed outpatient day unit, in terms of how many patients we can actually see in the perform outpatient CAR-T and transplants. So what we've started to do is engage with the community. And there, certain centers have already started to look at having little satellite day hospitals. We were going to identify lower risk patients who can actually be followed in the outpatient setting using our same model, but at another site. So there are many different ways to try to expand on the capacity locally.
I'm just going to add one thing, that we're also looking at a model that is a hub and spoke, type of model where you have maybe a command center here, but many different, spokes in the communities or other centers.
And probably once a new system like yours are in place, it provides new opportunities for optimization. So maybe new digital technologies can further improve the scalability. So with that, I would like to thank all the speakers for this great panel discussion.